Camera
Hello?
off, yeah.
No, I'm keeping it off here.
Cool.
Let's see. Right. How can I tell if people have joined yet? Okay, fine, cool. Right. Hi guys. Welcome to our session on acute ophthalmic conditions. I'm gonna aim to keep this like quick whistle talk about the main acute stuff that you guys need to be aware of, and I'll be giving you guys a couple of heads up as to things that frequently come in MCQs, things that maybe you should look out for, or that give you hints to what condition there is, a couple of like cheat points as to how you can distinguish one from another, and then obviously we're going to be stopping frequently for questions. Atif, obviously you have also sat finals, so if you want to pitch in at any point, please feel free to just pitch in whenever you want. Right. So, sorry, very briefly to introduce myself. Maiar, I'm one of the F1s based in Birmingham Central. I'm currently based in Midlands Metropolitan Hospital. Right. And I have Atif, who is based in Birmingham South. And yeah. Anyway, so today we'll be covering very quickly red eye, what causes it. We're going to be quickly touching on loss of vision, more specifically sudden loss of vision, as this is more of an acute session. And then we'll be covering trauma. Okay, starting with the acute red eye. So there's many possible etiologies that could result in an acute red eye, ranging from trauma to inflammation, infection, glaucoma, hemorrhage, with obviously many different things that can cause them and many different resulting circumstances in terms of whether it could be just an acute or temporary change in your vision or have more detrimental effects. The main causes of red eye that we see generally presenting that are maybe not as are a bit more common. Your classic one is conjunctivitis. I'm going to get into each of these in a bit more detail, but I just thought we'll quickly talk about each of them. Your classic one is conjunctivitis. It's just an infection of your conjunctiva. You get redness of the entire surface of the eye. It just looks kind of red, and you'll have a normal pupil, clear cornea, so no change in pupil size, nothing in your anterior chamber. They will often present with different extents of stickiness or grittiness. They might also present with discharge depending on what caused the conjunctivitis. You also have episcleritis, which is basically, as you can see, it's not, the whole eye isn't as red as you would in conjunctivitis. It's more so the blood vessels are a bit more prominent, and visual acuity would be normal in comparison to other cases of red eye. They will present with irritation, however, their vision again will not be affected. Another one that you would urgently refer to ophthalmology is anterior uveitis, because a lot of the times it's associated with systematic etiology. This one would be more so around your pupil. You'll get this circumcorneal redness. You'll get a bit more of a constricted pupil appearance. People will come with pain, photophobia, pain on eyesight, and then they'll also have a bit of a watery discharge, and their vision a lot of the times is reduced. They might also, other causes might be a corneal abscess, which you will kind of see most of the times without having to look in the microscope, but if you put it in the microscope, it'll be even more out there. It's basically, again, generalized redness, very similar to conjunctivitis, except you'll see that distinct abscess either under the microscope or with your naked eye. You'll also get scleritis, another cause of red pain. It's very different from episcleritis, much more serious. Again, could be associated with more systematic features. We'll talk about how you can do them because that's a very common MCQ question. We also have the very common acute angle closure glaucoma, another ophthalmic emergency, and this one is very classically known for a mid-dilated pupil, comes on suddenly, really bad pain. It might also present with other systematic features like vomiting. Right. So what I think is really easy is if you split the eye into compartments. So if we quickly revise our eye anatomy, so conjunctiva, where you think about red eye, you think about Usually it will be in your anterior compartments because it appears red. So it could be any of these features that's affected. And depending on which feature is affected, you'll get the name. So if it's your conjunctiva, conjunctivitis, sclera, scleritis, and so on and so forth. With uveitis, what's important to know is that while anterior uveitis is the main focus, there's different forms of uveitis, which we'll also talk about in a bit more detail, like posterior uveitis or panuveitis. Right, going into the less severe end of the spectrum. We're going to be talking about blepharitis. Blepharitis is, in simple terms, just an inflammation of your eyelids or any of the associated structures in your eyelids. So that would be your eyelashes, the skin around the area, or even the glands around your eyelashes. And it has a very common association with seborrheic dermatitis. So a guy with seborrheic dermatitis presents with a red eye. Make sure you rule out blepharitis because it's an easy one to treat that you don't need to worry about, and it's a very easy one to treat that you don't need to worry about, and you just want to get it out of the way. Again, a lot of the times it will be bilateral as well. You will have that discomfort and stickiness, and they love asking you how to treat it for some reason. This one is just conservative management. So a lot of the times they'll give you a hot compress and they'll ask you to maintain lid hygiene. So a lot of the times what that will mean is just having cotton buds and just kind of basically brushing this off, making sure that it stays clean. Something that's really interesting that kind of stuck with me is when I was attending an ophthalmology clinic, they asked one of the patients to maintain lid hygiene using baby shampoo. I don't know if that's going to help you guys remember that lid hygiene is something, but if it helps, it helps. And we have also artificial tears. And then moving on to conjunctivitis. So there's many different causes. The two main ones that we're focusing on is splitting it into allergic or infective, right? It's allergic, it's usually systematic, obviously, so it'll be bilateral, be red, it can present with chemosis or basically swelling, it'll be very itchy, and a lot of times, as we know, allergy comes in packs, so it won't just be that's allergic conjunctivitis. They'll come with hay fever, with an asthma, basically a history of, for example, triggers or others might make you think, this is more of an allergic picture rather than an infective one. That being said, also, we need to know that with infective one, it's more likely usually to be one-sided because it's an infection. However, it can present bilaterally as well. If it's an allergic conjunctivitis, you'd manage it for most allergies, except a lot of the times it's just a bit more topical, so your mast cell stabilizers. With infected ones, you can split it into your classic bacteria. I won't ask you to distinguish between both. There's other causes, but these are the two main ones. And a very important thing to say, which I'll get into in a bit more detail, is a lot of the contact lens, if they wear contact lens, and they like to see you split, especially in OSCEs, they like to see you split it into lifestyle, medication, and surgical. Lifestyle-wise, you can say, I'd check if they're wearing contact lenses, I'd give them contact lens, even if they're not using contact lens, just general like eye allergies, that kind of thing is something that is really appealing to them because it shows them that you're looking at the bigger pictures and that you genuinely understand what etiology could be. Right, scleritis and episcleritis. This came up in my OSCEs, so we'll quickly talk about it and I'll tell you guys what questions came. So in very simple, episcleritis is inflammation of episclera, the layer right above, and then sclera is of the sclera, which is a bit deeper. To distinguish using a phenylephrine test, and basically what happens is this. So if you put phenylephrine and the vessels blanch, then it's episcleritis, because if you think about it, it's more superficial, so it's more affected by the drops. However, a lot of features can make you distinguish between both, hence why they don't need the test or do it as much. So with much more red, it will be more painful. They'll have a lot of photophobia. They could have a reduction in their visual acuity. Both of them can be associated with systematic features, but a classic link they like to make in MCQs is scleritis with either SLE, lupus, or with rheumatoid arthritis. And obviously, because they can both present very similarly, if you're unsure between both of them, just send them for urgent ophthalmological assessment to make sure you rule out scleritis. And then, as with most inflammation, you'd give NSAIDs, and if needed, you can give immunosuppressants. Moving on to uveitis, that one also came in my OSCE station. And it's basically an inflammation of anything along the uveal tract. So it could be anterior, so it's your iris or your ciliary body, or it could be a bit more posterior, so an infection of your choroid, for example, or it could be panuveitis, it's an infection of pretty much everything. Etiologies can cause uveitis, or an inflammation could be an infection or part of, for example, an inflammatory systematic disease, and the most common reason is just an idiopathic one. It's again full red eye. In this case, you have small pupils, and a lot of the times you'd have what we call a ciliary injection or a hypophon. We'll talk about this in a second as well. But basically, a hypophon is an accumulation of these pus cells in between in your anterior chamber, and a lot of the times when it accumulates to the top, it exerts that pressure and basically restricts the movement of your iris and ciliary body, and hence gives that appearance of that classic small irregular pupil, because it doesn't give the structures a lot of space to move. And a lot of the times it also results in that irregular pupil, because if you think about it, for example, the iris is stuck to the lens here, it's stuck to the cornea there, so it's not free to move, and it's not moving symmetrically across all across the whole diameter of your pupil, so it will look slightly irregular. With the slit lamp, you'd be able to see what we call keratatic precipitates. And a lot of the times, this is not just for anterior uveitis, it can indicate any inflammatory process, but you can also see posterior syncae, which is this adherence that we've just spoken about, which could obviously resulting in that buildup of pressure could eventually cause you to get acute angle. And it's very important to be able to make a distinction between both. And again, we'll talk about that in more details on a side. So as we said, if it's the ciliary body and the iris, anterior uveitis, if it's a bit more anterior, and then ciliary body ciliary body and iris again, but more intermediate, so a bit more in the middle, infecting the actual lens itself. Posterior uveitis if it's the track in the back, and then panuveitis if the whole thing is affected. My OSCE question was, they gave me a picture of this and they gave me a picture of that, two separate occasions, and then they asked me what this was and the etiology behind it, and what this was and the etiology behind it. So I very briefly spoke about different presentations, but can anyone maybe put a guess in the chat as to what, if you were presented this picture in your OSCE, would you say it is? If you're happy to please read from the chat, because I can't see.
Nothing in the chat yet. Anyone fancy a go? There's no silly answers here. That's why we're here to help you guys. So just any suggestions. Right, so we've got Yosef says the right one is a coloboma, and Adele says Hyperion.
So it's very, you guys are around the same line. So basically, this is what we've spoken about, which is the accumulation of pus cells in the anterior chamber, which is hypophon. And then what about and obviously this is just a result of inflammation. And then what about for the second picture? What do people think this is? Or even if you don't remember the name, what could potentially be causing it?
Any guesses, guys? Mr. Ola.
This was a bit harder, to be honest. Guys, imagine you're like in an OSCE and you're stuck and you don't know what to say. What would you just say? Just, you can throw a guess. Just describe, even if you have to describe what you see, or explain how this could have happened based on what I've just told you guys. Just have a go.
Maya, do you want to give them a hand?
Yeah, I'll do that. Thanks, Atif. Basically, this is what we call synechiae. Don't know if I'm saying it right, but it's another word for an adhesion, basically. And this happens, like we said, when the iris either sticks to the cornea or sticks to the lens. So if you imagine your compartment, and then your iris either sticks to the cornea, sticks to the lens, depending on where the cells are, where the infection is, just sticks to either one of them, giving you this irregular appearance. So here it could be stuck to the lens, and here where it's a bit bigger, stuck to the lens. There it's stuck to the conjunctiva. It just basically depends, and it just results in this very irregular appearance of a pupil. And as you can imagine, it's something that if you see in GP practice or someone who walks in, you'd urgently refer to ophthalmology. And also you want to make sure that it doesn't, that obviously you free that angle between that drainage angle, so that it doesn't result in acute angle closure glaucoma, which is, funny enough, our next topic. So normally, if you think about it, this is where the fluid is produced, aqueous humor is produced, and then it drains through trabecular meshwork, and this is your drainage system, and it keeps going. What happens here is the angle between your iris and your cornea gets closed due to, for example, raised intraocular pressure, causing the contents from the back of your eye to press on your lens, which exerts a force upwards, closing it. Or, for example, in cases of inflammation, like we've mentioned, where again it closes the angle, for example, because of an accumulation of corpuscles. And obviously there is a couple of risk factors that make you think, ooh. One of the common ones that they like to ask again, or they like to point to, is hyperopia. It's associated with acute angle closure glaucoma. People will a lot of the times present with this very painful, severe red eye. A lot of the times they might have nausea or vomiting, and they might report what they call halos around light or around objects. And then you might also get what we call corneal edema, so that cornea doesn't look as distinct. And the main thing that will tell you, obviously, there's a raised IOP would be your tonometry. So it's something that, believe it or not, actually touches your eye. And patients tolerate it better than I thought they would. And normally you'd expect your intraocular pressure to be lower than 21. And then just to make sure if that raised intraocular pressure is what's causing the angle closure, or if it's an even angle closure glaucoma, because raised IOP is something, and then angle closure, to confirm that, you use what we call a gonioscopy. It's a lens that basically lets you see this area, so you can see if that is closed, open, if there's any other etiology that's resulting or that's caused this maybe raise in intraocular pressure. Obviously, immediate management, you would do anything to try and lower their IOP, and the main thing that you need to know is acetazolamide. However, there's other medication that have different mechanisms of action, and if you think about it, it's fluid that's being produced and not able to drain. So your two key things that you want to do is, A, you either want to make it easier for that fluid to drain, or you want to reduce the production of fluid, or both. And then when it comes to actual definitive management, so this is all temporary, as in once the medication effect has worn off, the IOP will gradually begin to get raised again, and then again you could get the angle closure glaucoma. So when that happens, your definitive management, so you'd obviously manage them symptomatically first until you can book them in for a more definitive laser peripheral iridotomy. And this is, if you think what the name means, you're using a laser to cut through your iris and create angle for that fluid to drain. So it's a bit more peripheral as well. So laser in the periphery of your iris, and you make a cut, and then the fluid will drain through. What's really important, and I didn't actually know this until after I finished med school, is that glaucoma doesn't mean erased IOP. Glaucoma means damage to the optic nerve, right? Commonly caused by erased IOP. But what this basically means is an angle closure damage to the optic nerve, which is what you're trying to prevent from happening or prevent from progressing by reducing this IOP. Because as we all know, nerve damage a lot of times is something that's permanent, not reverse. But yeah, it's just something interesting that I thought I'd share with you guys. It's a very common misconception, and it's something that I know I didn't figure out until after I finished med school and actually went to an ophthalmology clinic. But yeah, we move on to sudden loss of vision. Are there any questions?
I think you can go on, Maya. I'll let you know if anyone messages anything.
So the first one we're going to be talking about central retinal artery occlusion. So with an arterial occlusion, you'll get this cherry red spot appearance on fundoscopy, MCQ, but I didn't really realize what it looks like, exactly what it looks like. You get a very pale in the blood supplying it, but you get this area which is very red, and this is your cherry red spot, basically, right? And a lot of the times it's essentially caused by a stroke, if you think about it. So it's either a thrombus or an embolism that blocks your artery. And if you think about it, thrombus is just basically something that built up in your retinal artery, or an embolism is something that was built up somewhere else and then somehow just dislodged there. You will also get what we call what you can also get wrapped with it as another very common appearance. But a lot of the times with MCQ, they will either show you this picture or tell you on fundoscopy she had a cherry red spot. What do you think the diagnosis is? And a lot of the times, if it's presented as part of a stroke, you will manage as per stroke, especially obviously depending on if it's thrombolic or a hemorrhagic stroke. More times than not, it's a thrombotic one that's caused this. So you'd manage it by giving aspirin, etc. A lot of the times also they give IV acetazolamide within the first 8 hours, and that's actually reported better outcomes. But most of the times in MCQs they don't really ask you about that, as far as I'm aware. It's always been more diagnosis rather than actual management, but it's just something to be aware of. Retinal vein occlusion, on the other hand, I also think is very interesting because it's what we call a stormy sunset appearance. So as you can see, it looks very angry, a lot of color there, and it has what we call flame hemorrhages. So I've highlighted the key a lot of times when CQs, someone with sudden painless loss of vision, they tell you, you look in the fundoscope, flamey hemorrhage, or it looks like a stormy sunset, anything like that, just go straight retinal vein occlusion. And this one, again, is very similar risk factors to the arterial one. So any CVDs, ocular disease, glaucoma, other stuff. And then a lot of the times with this, it's more conservative management. So you'll give like, try and stop new vessels forming or manage the hemorrhage, as well as laser coagulation. But again, with both the conditions we've just spoken about, a lot of the times they don't ask you about the management, they just ask you to diagnose it or distinguish between both of them. And the main distinction between both of them, because they both present with a painless sudden loss of vision, is that fundoscopy appearance, and as you linked between both. Right. Then we have retinal detachment, and that is described, classically they'll tell you, I feel like, ooh, a curtain or part of my vision has disappeared, right? If you think about it, it's basically because the contact with the photoreceptors has been lost at some point. So that area in their vision just appears black. So it looks like there's a curtain in that area, in that area. And then again, there is a couple of risk factors associated with this, and the most common one is vitreous detachment, which just happens with age and is also linked to diabetes. It is also linked to myopia, and sorry, it's also linked to myopia, and it could be, if you think about it, just some sort of eye trauma that detaches the vitreous, and then retina detaches as a result. If you also imagine it, the vitreous humor is what kind of exerts the pressure on it and makes sure it's stuck in place. And once it starts to detach with age, the retina is not held as strongly in place. There's not that much of a strong pressure on it, so it begins to peel off. On fundoscopy, you might get a loss of your red reflex. And a lot of the times for definitive management of this, most of the time, more times than not, they'll actually leave it alone, but your definitive management will be either a vitrectomy, again, like we said, because it exerts that pressure, so you want to make sure it's kind of held in place, or if from inside the eyeball doesn't exert the pressure that you need, you will do it externally by what we call a scleral buckle, and that's basically just tightening it to your so tying your retinal layer to the sclera to make sure it doesn't wear off. So like if you imagine just putting like a tie here, like a tape between your retina to the and then from your retina to your sclera to make sure it's held in place. Then we have anterior ischemic neuropathy, again, very, 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 very commonly associated with your giant cell arthritis or temporal arthritis. Old woman, jaw pain, tenderness around, and then you get that tenderness, just, or anything basically where they describe giant cell arthritis, just think it's probably associated with an anterior ischemic optic neuropathy. And in fact, it is the main reason that giant cell arthritis is an emergency, because it can result in vision loss. With this one, you'll give IV methylprednisolone. And if you think about it, with giant cell arthritis, you normally manage it with steroids. But once it starts to include vision, this is where you get to danger category. So you'll go for IV methylpred straight. One of the key things to confirm diagnosis, because it's associated with GCA, is your temporal artery biopsy. However, if you guys also remember, that has skip lesions, so it might not be the most accurate way. But again, you'll have that pale disc, blurred margins. It will look a lot like a raised IOP. But yeah, it's just the history that will tell you, or that will help you, I guess, make a more definitive diagnosis as to what the actual cause is.
Hey,
Optic
Maya,
neuritis. Yes?
just before we go on, Adele had a really good question. Just going back to central retinal artery occlusion. She says, would the CRAO fundoscopy appear the same as with TIA? So that cherry red spot, I think, is what she's talking about here.
Sorry, repeat the question again.
So would the CRAO fundoscopy appear the same as with TIA? So I think, Adele, correct me if I'm wrong, are you asking, would you still have that appearance with someone who has a TIA rather than a confirmed stroke? So essentially the question is, Maya, in a TIA, would we also have that same appearance?
So with a TIA, a lot of the times what classes as a TIA is that it's not a permanent damage to the actual tissue structures involved. If you're catching them while they have the TIA and there is a restriction to the blood supply, then there is a high chance. But it does take a time for obviously these effects to manifest, and I doubt that you'd be able to see it for someone who's presented after a TIA episode. And I'm not too sure I know of a lot of people that present while having a TIA. So I'm gonna say more likely not, unless you obviously catch them while they have a TIA. And again, it depends on where that TIA is happening. Is it happening in their central retinal artery? Is it happening in a carotid artery? It just really depends on the site and how long it's been going on for. And just remembering that obviously with the TIA, it's just a temporary thing. So it's a matter of, are you catching it as it is happening and as there is a restriction to the blood supply and hence you're getting that picture? Or is it after that occlusion has resolved and your tissues are no longer affected? In which case you get a normal appearance of a retina, but you might have been able to see this if you caught them while they were having a TIA in the central retinal artery. I hope that answers the question. If it doesn't, please let me know. I mean, unless you think I haven't answered it as well, Atif, but I think that's what the question is.
Yeah, no, I think you've done a good job at explaining, Maya. But Adele, if you want any further clarification, just pop another message and we can go back.
Yeah, I was gonna stop for another question break in a second as well. So, please do drop any more messages, or if I could explain it better, if we maybe misunderstood your question, just please let us know. There's obviously no stupid question, and we're just here so you guys like I said. Right. So then with optic neuritis, it's one of the favorite MCQ questions. They ask a lot about it. Especially in association with multiple sclerosis. So it's an inflammation of the optic nerve, and it's also common in syphilis or diabetes, but again, it's usually in association with MS. And the classic thing they'll give you in an MCQ question is the classic red desaturation, or a bit less common is just poor color discrimination. And this is just what they would see, and this is what a normal person would see. That's what they mean when they say poor color discrimination, and especially the red appears desaturated. Their optic disc might appear normal actually, but you would diagnose it because a lot of the times associated with MS or other demyelinating conditions is by making a contrast MRI brain and orbits. And again, a lot of the times either of these conditions could be treated with a high dose anti-inflammatory, so you'd go for your classic IV methylpred. Right. Then we move on to traumatic causes of eye, but before we do, are there any other questions in the chat?
Not just yet.
Okay, amazing. If you guys have any questions, please feel free to pop them as we speak, and please, Atif, do as is needed. Fine. Very quickly going into trauma, I've split it into three main things. So, going very briefly, starting actually from this end, chemical injury, acid attacks were actually very common at some point in Birmingham, which is a bit scary, especially as a result of fights. And if you think about it, what you would do when someone presents with a chemical that's been thrown is you'd make sure you wash it out, try and wash it out as much as you can. So we do this irrigation where you basically just put a lot of water in their eye and make sure that you try and get as much of that chemical out. And then a lot of the times, depending on what the resulting injury is, you might need to give them cycloplegics, steroids to reduce the inflammation, maybe even antibiotics if it's resulted in, for example, ulcers or any form of epithelial loss. And then a lot of the times you also give them topical vitamin C because it's an antioxidant and it helps with immunity in general. So again, it helps fight off any microorganisms or help with any epithelial loss. Then you have a bit more of the serious end of the spectrum. You have, they're all emergencies, by the way. But you could have an open globe injury, and that could either be a globe rupture, so your eyeball's literally ruptured. It's no longer, if you think about it as like a ball, it's just ruptured, or a balloon is just popped. It's no longer has that structure. Or a laceration, which is basically a penetrating injury, so it's gone through the layers, but it's still that spherical appearance. They'll have a lot of pain, again, loss of vision. They might have intraocular prolapse. They might have lacerations, obviously, which might be apparent or not so much. And with them, you might want to give, depending again on the site of injury, you might want to give tetanus prophylaxis, as we know, for any open wound or anything that's exposed to the outside. You want to check for their tetanus records, and you might want to give them a shot. And a lot of the times with a laceration or again, a rupture, anything else where you suspect that something might have penetrated the eye, you might want to do an x-ray just to make sure that that thing is no longer there. You'll give them a plastic sheet and straight refer them to ophthalmology. And depending on the extent of the injury, how much can be saved would be decided. With blunt injuries, it's more of just a direct blow to the eye. So it could be, for example, a blowout fracture, and a lot of the times it could result with a hyphema. And I used to always confuse a hyphema with a hypophon. So a hypophon is basically that pus accumulation in the anterior chamber associated with inflammation, like anterior uveitis. Hyphema, on the other hand, is blood in the anterior chamber as a result, more times than not, of trauma, right? They can also get vitreous hemorrhage because of the vessels at the back of their eye have also been subject to that trauma, and they can get retinal detachment, as well as a globe rupture. A lot of the times you would do a cold compress and analgesia, and you want to obviously do an x-ray to just check the extent of it. They might require surgery again, and then depending again on if there's, for example, blood in the anterior chamber, it might again press on that drainage angle of the aqueous humor and results in glaucoma or an increase in your intraocular pressure. So you might want to manage that accordingly. And yeah, that's pretty much it. Was talk of your traumatic causes. That's it from me. I don't know if you guys have any questions. I'm more than happy to stay back, but this is the feedback code. I'll also put in the chat, and I'll stay back for a couple of minutes. Are there any questions at the moment that you can see out of?
No further questions, but I will add on just a couple of things to the end of the talk. The first one I would say is that ophthalmology is not very commonly keen amongst medical students. You know, a lot of people don't really bother taking the time to learn about the conditions. But like Maya mentioned earlier, you're very unlikely to get any MCQs that are going really in depth in management and really niche knowledge. My experiences during finals were that the questions that come up were very kind of straightforward diagnosis with a little bit of thinking around it, or very straightforward management. And it's worthwhile spending an afternoon or a day going through your ophthalmology MCQs and your revision, because then it's easy marks in the exam because the questions are not going to be difficult. And I would also echo what Maya was saying about her OSCE experience, because she got an ophthalmology station. I also got an ophthalmology station. So I got neuro ophthalmology, and I had to do visual field defects and all of that and come up with differentials of a pituitary adenoma. And the people who didn't bother doing any of their ophthalmology learning because they thought it was so low yield or so irrelevant, a lot of them then did poorly when it came to the OSCE stations. So if you've got your finals coming up, you don't have to spend huge amounts of time learning ophthalmology because, yes, it is low yield, but you should still put the effort in to learn at least the basics, because you don't want to get caught out if you do get an OSCE station and it's easy marks in your MCQ.
Yeah, I was gonna say, because it might be a couple of questions in MCQs, like a point or two, but if you get it as an OSCE station, that's an entire station, and it's an easy one more times than not to score points in, so it's not something I would dismiss like Atif's advising.
The one other piece of advice I would give all of you is that NICE CKS do a really good summary of red eye. I will copy the link into the chat now, but if you were just to read through this link and go through CKS and see what they have as their differentials for acute red eye, see what advice they would give to patients, and also the basic management for all of these, then you're not going to go wrong. Because in an OSCE, if you get a history from a red eye and you go through all of the red flag symptoms that NICE have listed out really nicely for you, then you're going to pass that station. There is one more question from Aparna. She says, or he says, sorry, thank you so much for the presentation, was very helpful. I did want to ask, what's a blowout fracture? Maya, do you want to take this one?
Let me get a picture. I feel like, can you hear me?
Yep.
Can you hear me? Okay, I'm gonna get a picture. I don't know why I didn't think to put a picture. Like that would be a better way of explaining it. Right. You guys can still see my screen, is that right?
Yeah, we can.
Okay, amazing, right? So this, I think actually this is a very good picture. So if you think about, this is your normal orbit, right? And this is the floor. It's very intact. All the bones are kind of closing up on each other. What happens with a blowout is, for example, as a result of trauma, so someone got punched, part of your wall just basically breaks off, or part of your bones just break out. That is what a blowout fracture is in simple terms. And then also a very interesting one that sometimes might come up. If you can see here, this should be filled with air, whereas a lot of the times if there's trauma, it has this less, what's the word? It has a bit more of a radio opaque appearance in comparison to this very dark appearance, and that's one way of distinguishing it. Another picture is here. You see this versus this. That's another blowout fracture. It's basically a fracture of your orbit in simple words. To be fair, I think these are a lot less yield than the other topics we've discussed. That's why I just very quickly whizzed through them. But obviously, you're more than welcome to ask any question. You're welcome.
I'll give you guys another minute. If you've got any other questions, just pop them in the chat.
You're welcome. Here it is.
Awesome. Thanks very much, guys. Best of luck with your finals and your exams. You're all going to smash it, and you're going to score 100% on all of your ophthalmology questions, thanks to Maya.
No, thanks to you, Mom. You're welcome, guys. All right, I'm going to stop sharing my screen. Right, Adif, thank you so much for your help. I'm gonna stay back for like maybe 2-3 more questions, but you're more than welcome to leave if you want to. I'm just gonna make sure there's no more questions because technically the session's obviously until 8. But yeah, thank you so much for all your help.
No worries. I'll speak to you soon.
Take care. Bye.
Bye.